Welcome to Talk Dizzy to Me, the show that brings you a comprehensive look into the complex field of dizziness. Now here are your hosts, vestibular physical therapist Dr. Abby Ross and Dr. Danielle Tolman.
Welcome back, everybody, to a new episode of Talk Dizzy to Me. My name is Danielle Tolman. I'm a vestibular physical therapist, and as always, joined by my co-host, Dr. Abby Ross, who is a vestibular physical therapist and a neuroclinical specialist. And today, we are very excited to have Dr. Rob Lindell on to talk to us about all things cervicogenic dizziness. This has been something that we've only briefly touched on before, and I'm so excited to take a deeper dive. So, Rob, thank you so much for joining us today. Would you please introduce yourself and give us a little bit about you and your background and what you got into this specialty?
Well, first of all, thank you for inviting me on. This is really a special treat for me. I've listened to a number of your episodes, and they are fantastic. And I'm trying to put the word out in my meager ways about what you're doing with the podcast and everything that you all are doing. So very, very pleased, excited to be here. I got into treating patients with dizziness when I was trying to build our faculty practice at USC a long time ago. You know, back when the only thing we really had at the time was habituation therapy, and everybody got habituation therapy and didn't even know what BPPV was, and Epley hadn't published his paper, and reposition, what the heck? So I've been working with patients with dizziness for a long, long time. I came out of a background in orthopedics or MSK, and I was very used to treating, the neck. And people would come in and say, well, my neck is, I'm dizzy, but my neck is sore too. Well, let me start with that because that's what I was more comfortable with. And lo and behold, I'd see their dizziness change. And just started a lot of questions in my mind. And I started following. I'd go to conferences and I basically creep on the big names in vestibular rehab. I'd go to Susan Herdman's talks and then I accost her afterwards. Hey, what's going on with the neck? I don't know. So, but we've come a long, long way since those days. And now you can see a lot of papers that are relevant to the area. So we're starting to understand it more. We have a long, long way to go still, but it's been an interesting journey for sure.
I love when guests bring up how far we've come in such a short amount of time. I mean, this is within your time of practice where we didn't even know about the Epley maneuver. It's just mind-blowing to me. But cervicogenic dizziness is definitely an area where I want to learn more and expand my own practice because it is a little intimidating to me. You know, I feel so comfortable in so many skill sets relating to the vestibular system. But when it comes to neck involvement, especially because I treat primarily via telehealth or virtual care, I could definitely use a little bit of tune-up here. So I'm really excited to have you on. And shout out to Dr. Carly Lacala for connecting us with Dr. Lindell. She's one of our therapists here at Balancing Act Rehab. She's on the newer end, so if you haven't heard of her yet, go ahead and look her up. She's amazing. Let's get into cervicogenic dizziness. First, I want to talk about how we actually define it from a clinical perspective.
So first of all, a big comment. You are not alone in being very comfortable treating the dizziness and a little less comfortable managing the cervical aspects of it. So it's not an easy entity to really identify, but there are certain things that you look for as a clinician to say, I think this the neck is involved. One of them would be neck pain that occurs with the dizziness. So you have both of those going on at the same time. It's a little easier to say, I think the neck is part of this. When the neck pain gets worse, the dizziness gets worse, or vice versa, so that the two are connected in some way. Some people talk about dizziness that gets worse when you move your neck. That's hard to really tease out because you're also moving, since you're moving the head, you're moving the vestibular system and you're stimulating it. So that by itself could cause dizziness. One of the hallmark things, though, is the dizziness. Although it's called cervicogenic dizziness, dizziness is a very broad term, and we are not talking about. Dizziness could generally include vertigo, which is a sense of movement of self or surroundings, but cervicogenic dizziness does not include vertigo. So you don't get spinning, you don't get rocking, you don't get bouncing or swaying up and down. You don't get those sense of movement of self or surroundings. More often, what you will hear from patients is they'll have balance problems, and not balance. This is what's tricky. It's not balance that is so severe that you're falling over. It's I feel unbalanced. I feel like I need to touch the furniture, what we call furniture walking. I feel like I'm swaying. So my body, I am swaying. So it's not a sense that the world is swaying around me, but I'm not steady on my feet. That is also a very common complaint. But it's there are a lot of things. We don't typically get nausea with it. However, and here's again why cervicogenic dizziness is hard to pin down. It doesn't really, in my experience anyway, it doesn't really occur by itself. Oftentimes it occurs with a vestibular problem, peripheral vestibular problem. So something wrong with the inner ear, or a central vestibular problem. So something going on in the brain. So a classic presentation would be traumatic onset, where you've had a concussive event. Maybe you're diagnosed with a concussion, but that blow that was severe enough to cause an injury to your brain is also going to transmit forces into your neck. And so your neck suffers an injury at the same time. So now you complain of headaches, dizziness, imbalance, and a myriad of other problems. But because of that event may have damaged the brain, may have damaged the peripheral vestibular system, may have damaged the neck, as a clinician, I have to figure out what's coming from where, and that's the tricky part.
Now, you had mentioned, the primary injury, like a whiplash injury, a concussion, something traumatic. Could you have cervicogenic dizziness as a secondary condition, whereas we had vestibular dysfunction, which led to a lot of movement in block, not wanting to move that head, kind of moving everything together, and now we start to get tight and guarded? Could that potentially come on in these presentations that we tend to see in the clinic of layers of issues?
Yes, that is quite possible. As you say, it's very common for, if moving my head around makes me dizzy, I'm going to stop moving my head around. And I tend to move more slowly. And as you say, in blocks, so the body and the head move together. And if you do that for a while, your neck gets stiff. And so now you develop some secondary MSK problems, some musculoskeletal problems in the joints, the muscles, and so on. And that then can add to the problem and add a cervical component to the original problem, which maybe started in the vestibular system.
I feel like cervicogenic dizziness is one of those diagnoses that is maybe controversial is too strong of a word, but I feel like there are people that are really gung-ho about it, and then people are like, nah. So in your practice, or from your perspective, would you say cervicogenic dizziness is overdiagnosed or underdiagnosed?
It's hard to say from my practice, because I tend to get a lot of folks who have progressed to a certain point with vestibular rehab, and they sort of plateaued, and then, hey, Rob, will you take a look at this? So it's hard to say in my practice, but I would say that there is definitely a pendulum where it's none, and then the pendulum swings, and everybody has it, and the truth is often somewhere in the middle. I would say it is underdiagnosed by medicine, in the sense that we often, if you're working in an orthopedic clinic, treating a lot of spine patients with spine issues, and you'll get patients that are diagnosed with whiplash, right? Now, in my view, if you've had that traumatic event to your neck, I'm going to ask about whether or not you're having any symptoms of dizziness, some of the symptoms that we've talked about already. That's not the norm, okay? And not everybody who has had a whiplash event is going to have those symptoms, but a lot of them will. And so for me, it is a standard part of my evaluation in someone who's not coming to me for anything, related to dizziness or balance problems, but they have a neck issue. And I'm just gonna make sure there isn't anything hiding in there. Okay. Flip side of that, so that's a patient with a diagnosis of whiplash. You get a patient with a diagnosis of concussion, and they come in, and they are complaining of dizziness and headaches and things. But from the medical standpoint, well, it's concussion. What do you think of? Well, you've hurt your brain, right? I translate that diagnosis of concussion into concussive event, and so that, if you think about it as an event, if you're a clinician and you think about it as an event, then you can get away from the diagnosis of concussion, oh, the brain has been injured, and more into what could have happened during that event. Well, the head, there was a blow to the head, so could have affected the inner ear, and clearly could have also affected the neck. So I know it's a long-winded answer, but
It really reminds me that, I feel sometimes, especially when we get into specialty care, we're a little bit narrow focused because we know what we know and we kind of forget what we don't know. And it really begs us to zoom out a little bit, especially for those patients, like you said, that often get referred to you where they do well, but then there's this little bit remaining here. What's going on? Maybe their symptoms sound a little bit vague. Maybe they're like 90%, but they can't seem to get over that last little hump. And perhaps it is because the neck is involved. So when you think about vestibular involvement, neck involvement, we've touched on a few diagnoses already, but what other specific vestibular diagnoses do you often see the neck involved?
I don't know that I can say that there is well, I see these two go together, right? So I'm not sure that I can have a straightforward answer to that question. If you have BPPV, okay, very common, and there are a lot of reasons why people have BPPV, but one of the most common is that there is some sort of traumatic event in their history related to the onset. I think it's like 18%, 20%, something like that. So 1 in 5, let's say. Okay, well, there's trauma there. Do you have any neck pain with your, have you? And so that would be my first question. And this is why I go back to, well, neck pain and dizziness, if they go together. If there is neck pain, I'm going to investigate the neck and convince myself that it's not part of the problem. And if there are some issues there, then, well, let me go treat those and see if that has a positive effect on their symptoms. Does that make sense? So that would be one that can be hiding in there. But, you should always ask someone has BPPV, when did this start? How did this start? What's the mechanism of injury? And if there's trauma involved, yes, go for that. Other than that, if you've got a unilateral vestibular loss, that typically doesn't necessarily go with cervicogenic dizziness, other than, as Danny was saying, as a secondary, it comes on afterwards from lack of movement and so on.
Do you see a lot of migraine having cervicogenic issues as well, kind of going hand in hand?
I always check. So migraine is another tricky one, right? Because you have headaches. Oh, so normally when we say migraines, we're thinking migraine headaches, right? And so we have to move away from always attaching headache to migraine, and also because there are migrainous vertigo or vertiginous migraines. In other words, the symptom of the migraine, rather than being pain in the head, headache, the symptom is now dizziness. And the tricky thing with that is if it's a migraine headache, because to have a vertiginous migraine, you have to have sort of the hallmark signs and symptoms of a migraine. Plus, at the same time, you have some of those, you also have vertiginous symptoms. Well, if you've got a headache you could also have a cervicogenic headache. So part of that headache could be coming from the neck. Now, there are criteria. The International Headache Society has criteria for vertiginous migraines, for migraine headaches, and the various types of migraine headaches. They also have a criteria list for cervicogenic headaches. And so you need to dive into those criteria and determine whether or not that headache is influenced or coming from the neck, or part of it's coming from the neck. The dizziness could be coming from the neck. And then there are the migraine components, and are there triggers, and so that's why it gets complex. And for me, it's exciting because I get to put on my Sherlock Holmes hat and try to sort it all out.
Absolutely. And again, it leads us into that direction of patients are complex. No patient is the same. And we really are investigating all throughout our assessment to try to figure out what's the root cause here and what do we need to address first, and then second, and then third. And usually it's not just that first thing that does the trick to cure all. Before we get into the actual assessment piece of it, can you explain how input from the neck contributes to our sense of spatial orientation and stability?
Sure. So the brain, in order to figure out where it is in space and where body parts are relative to one another, uses multiple inputs. Okay. So from our body, we get input from our joints, what we call joint proprioception. It tells us how much a joint is bent or if it's moving or not. But we also get pressure information. We get light touch. We get even the skin, the hairs on your skin give you input. And then there are a lot of free nerve endings in our fascia. So fascia is the connective tissue that kind of holds us together. All of that information tells us where we are in space and where we are relative to our environment. Okay. And so we lump that together and call it somatosensation. And then we can also tell, as far as in maintaining our posture control, we use information from our eyes. So as an example, if I am standing upright and I start to sway forward, it'll look like the wall is coming towards me. And my brain goes, the wall didn't move. I live in California, so sometimes it moves, but most of the time, the wall is stable. So clearly, the wall didn't come towards me. I must have gone towards the wall, right? So your brain goes, you must be swaying forward. And then we also have our vestibular system, which tells us, gives us information about movement of the head. So we've known for decades and decades that if you injure a joint, like let's say you have an ankle sprain, you will lose some of your ability to tell where the ankle is, and you're more likely, actually, if it isn't part of the rehab program, to regain that sense, you're more likely to re-injure your ankle, to sprain it again, right? You can't tell when it's starting to go over, and so by the time you can tell, it's too late, and now you've sprained your ankle again. And the same thing can happen in the neck, right? So we sprain our neck, and now you can't tell, whether your neck, how far your neck has turned, let's say. A big difference between the lack of information that we have at the foot and ankle and lack of information at the neck is that in the neck, we have the other two systems, vision and the vestibular system, that are telling us about head movement. So what happens if and normally those three will always agree. Okay. Well, what happens if they don't agree? So as an example, I turn my head 20 degrees, right? And my eyes say, yeah, you went 20 degrees. And your ears go, yeah, you went 20 degrees. And your neck goes, you went 10 degrees or 30 degrees. Okay. It doesn't agree. And your brain goes, wait a minute, where is my head? Which one am I supposed to believe? And that mismatch is what causes the symptoms. So the best analogy that I can give for that would be, if you go below decks on a boat and it looks stable, right? Because you're in your cabin, let's say, and it looks like it's very stable visually. It's not moving, but you can feel your sensory system is feeling that, oh, the boat is actually rocking or swaying. And your vestibular system is telling you that things are moving. And it's that mismatch between the senses that causes seasickness, right? So it leads to symptoms. So that same kind of mismatch is created when the neck is giving you inaccurate information, doesn't agree with what the eyes and the ears are telling you, and you end up with symptoms.
I will say that I do get seasick. I am under the firm belief that we all belong firmly planted on land. I think it's an evolutionary thing with our vestibular system. So yeah, it's not fun at all. It's not a good feeling to have, whether it's your neck or whether you're on a boat. But
I will just say I'm in the same boat. Pun intended.
Pun intended. I like that. Let's dive into what your assessment looks like, starting with the history. What are some things that we should look out for in a history when working with a patient that make us think or wonder if there's some cervicogenic issues going on?
So the first thing is to ask them, why are you here? I'm dizzy. Okay, well, what do you mean when you say dizzy? What do you mean? And as I mentioned earlier, dizziness is a very broad term, and it could include vertigo, which is that sensation of movement or itself. But it could include imbalance. It could be the feeling you get when you stand up too fast, and you get lightheaded. So it's a pretty broad term. So I spend actually, think about the percentage of time that I have with a patient. I will spend a significant amount of time trying to understand as best I can what their symptoms are, and really diving into, when you say dizzy, what does that mean? And then one of the key things I will ask is, when you say dizzy, are you spinning? Yes or no? And they say yes. For me, that nudges down cervicogenic. Are you rocking? Are you swaying? No. Or is the world rocking or swaying or spinning around you? Then cervicogenic dizziness drops down. But I do spend a lot of time on that. Even if it ends up not being the neck, that's going to help me with treating the vestibular problems. One of the next questions, not the next, but it flows. But one of the next things I need to know is the onset. So tell me about how this started, when this started. If there was no trauma involved, I'm a pretty simple guy, right? I like binary PT. It's either this or it's that, right? And I like questions that will lead me down that road or down that road, this or that road. And so if you ask about, how did this start, and you're looking for a traumatic onset versus an atraumatic onset. So trauma, then we were thinking torn stuff, broken things, rips, tears, sprains, strains, and so on. And we'll go down that road. And if there's no trauma involved, then we go down maybe overuse, inflammations, itises, and so on. In the vestibular world, if there's no onset, this just came on suddenly. Okay. So not by rolling over in bed. No, I was just sitting there and wham, I just got dizzy all of a sudden. That's leading me down the road of a vestibulopathy, something along those lines, right? And so I'm going to investigate that much more closely. So the mechanism of onset, the timing of the onset, those kinds of things are really, really important to try to figure things out. And then another big piece would be, do you have neck pain as part of it? So if I'm thinking cervicogenic, then I'm definitely going to explore, do you have neck pain? When do you have neck pain? When you have neck pain, how bad does it get? When it gets bad, does your dizziness get bad? How bad does your dizziness get? So I'm looking to establish that there's some connection in timing or onset between that neck pain and the dizziness that they're having. All right. So so those are sort of some key forks in the road, if you will, for me. I will always, because of the patients that I get are typically pretty complicated. I will always ask about, do a history for neurologic involvement, and I will always do a neurologic exam. So for me, exam is not just myotome, dermatome, and reflexes. So sensation, strength, and then reflexes. It's definitely those, but I'm also doing my neurologic exam, looking for hypertonicity, looking for rapid alternating movements, and so on. So I'm looking for essentially if there is any issue in the brain that I should be concerned about. So cerebellar problems or stroke and things like that. So that helps me rule things out and rule things down, and anything that time out as a PT, you really don't belong with me. You belong with somebody else. So I'm looking for what we call those red flags. And then from there, I'm looking to see if there's a central or a peripheral cause, try to separate those out. So does it come from the brain or is it coming from the inner ear? And then once I've gone through all that, then I start looking at the neck. So that's my sequence, if you will.
I like that. So it's kind of like a diagnosis by exclusion. We're ruling everything else out as possible causes, starting with that really important history. I mean, we've said on multiple episodes that listening is everything, and being able to guide your patient into answering the right questions, really makes a difference in having a comprehensive examination, knowing what to look for, what to anticipate. So I really like that. That just solidifies everything that we've been talking about in the past. But let's talk about some of those specific exam techniques. So say we've ruled out neurologically, central issues, peripheral issues. What kind of things are you looking at to assess for cervicogenic dizziness?
I think one of the key things is trying to determine if you do something to the neck, if that changes their symptoms. So the problem is if I have the patient stable, just sitting in a chair, for example, and just have them with their body still turn their head. The problem with that is, the neck moved. Let's say they turn their head to the left and they say, "Okay, I'm dizzy." The problem with that is they've moved their neck, but they've also moved their head, and so they could have stimulated the peripheral vestibular system with that, and so it's really not a diagnostic test. So what I need to do, I think one of the first things, and I think this is very, very important, is to try to separate out neck movement and head movement. Okay. So what I will do is I will hold the head still and move the body underneath. Okay. And if they get dizziness with that, then you kind of think, well, the head didn't move. So it's probably not, I didn't stimulate the vestibular system, but I did move the neck. And so that would implicate the neck. And for a long time, that was like the test, and it's in textbooks. You can find it. Sometimes referred to as the neck torsion nystagmus test. The problem with that, it was actually been known for 20, 30 years now, that's not really very useful. And the reason is, you could have, if you just consider for a second that, I hold my head still, I move my body, and I get dizzy. You could still have a peripheral vestibular problem that test hasn't really identified. And so what you need to do is you need to now stabilize the neck. So we stabilize the head, move the neck. Now we need to stabilize the neck and move the head. So imagine putting a collar on and stabilizing the neck that way, and then moving the whole body. So the head will move with the neck, with the body. So we've referred to this already. You would move en bloc as one piece. Now, in practice, we don't put a collar on. You can just stabilize with your hands and turn them and see whether or not that causes any problem. So you can see that if I were to stabilize the neck and move the head and body en bloc as one piece, if that caused symptoms, well, it didn't come from the neck because the neck didn't move. So that implicates it was the head movement. Now, it doesn't say it's a peripheral vestibular problem. Could still be a central problem, but you can say now that it was the head movement that caused the problem, right? So going back to my assessment, I call this the head neck differentiation test. And there's actually a nice paper that describes it, and other papers that include it in their assessments. And I think it's a nice way, clinically at least, to say, oh, I'm going down this road towards the neck. or, the neck doesn't seem to be involved. I'm going to go down this road and really concentrate on the vestibular system. So to me, that's a really, really important assessment. If I am thinking the neck, then because of that sensory mismatch that we were talking about earlier, I want to assess how accurate the somatosensory information from the neck actually is. And so we have what we call the cervical relocation test, or the joint position error test in the cervical spine. And essentially what you do is you put a laser, a headlamp laser on the patient, have them fix their head in a position that's neither left nor right, nor up nor down. So a neutral starting position. Put the laser on a target, and then they close their eyes, turn their head, and they with their eyes closed, try to bring their head back to that starting position. And we know that this has been shown in study after study after study, that 4.5 degrees, you should be come back to that starting position within 4.5 degrees. And if you don't, then there's a problem with your cervical, specifically with your cervical relocation. But the problem is that you can't tell from the information your neck is giving you where your head is in space. So that joint position error test is what I'm going to do on almost everybody if I'm thinking, everybody if I'm thinking the neck is involved. And if I have patients with just neck pain who aren't complaining of dizziness, I'm doing it as well, because just like I would with an ankle sprain, I would assess it. And I would argue that laser, using the laser and that cervical relocation test, head repositioning accuracy, it's got a number of names out there in the literature, but I would argue that our ability to test the cervical spine's ability to relocate is better than we have in almost any other region of the body because of that. So even in our ankles, where we know it's important to reestablish that joint position sense after an ankle sprain, we don't have great ways to measure how useful that information is down there.
Those are some really good tests. And I did not think about, I don't know why I didn't think about this, but bracing that neck and moving the whole body and block. I know we've probably talked about it at courses, but we're always so used to, holding the head still and rotating the body underneath it. So I think that's a really great point to be thorough and, testing the other side of that theory to see if it is more head movement or neck movement. Yeah. So
one thing, if I can add to that, so I used rotation as an example, but basically you need to do the thing that they do, right? So if they say I turn my head, I get dizzy. All right, we're using rotation. But they say I look up and I get dizzy. There's a way to do that as well, right? So you hold the head still, have them lean forward. The head doesn't tilt in space, but the neck has gone into extension, right? And then you hold, stabilize the neck, and you move them in block, lean them back. The neck hasn't moved, but their head has gone into extension, and see what happens there, right? So those are very straight, plain, kind of easy things to figure out. But you need to identify what movement it is reproduces their symptoms, and then do that with head only, neck, head stable, neck only moving, and then neck stable, head only moving.
That's really great. I feel like there's a lot of light bulb moments in that where I'm like, that makes total sense. Now, one question about that too, I know you're looking for symptom replication, but are we also observing for nystagmus? Would you do this with a set of infrared goggles on?
Yes, you can look for nystagmus. However, if it's not there, it doesn't mean anything. If it's there, then you have to go investigate it and watch the direction of nystagmus and try to make a call based on that. But just know that it doesn't always, if it doesn't produce, it's, again, originally it was called the neck torsion nystagmus test, but it doesn't always cause nystagmus. So if it doesn't, that to me is not, okay, that's not very sensitive to say, I'm going to rule that out.
That's also very interesting. So now, say we've got through our assessment, we've figured out that cervicogenic dizziness is likely a root cause of what's going on. What does treatment look like for patients with cervicogenic dizziness?
The treatment is a little bit of treat what you see, right? So, if we're really thinking the cervical spine is involved, the neck is involved, then I have to go do a decent examination of the musculoskeletal system of the neck. So I will be looking at active range, which is all 7 bones, 8 segments, movement segments, and look what's going on there. Identify if there are any movement problems at any particular level. Treat those movement issues, which again, binary. We could say they're either hypo, they don't move enough, or they're hyper, they move too much. Stabilize the hyper, exercise. Mobilize the hypo, manual therapy, stretch, and then exercise. Find those musculoskeletal issues and impairments and treat those. In there as well, we're looking at head repositioning accuracy, and if they've got problems there, then we're training them to get back to that neutral position. Having said that, that's what the test is. But, in life, we don't always come right back to the center, right? We're looking over here and we look over here and whatever. And so the treatment, once they get good at coming back to us, a neutral starting position, we can have them coming back to off-center positions, and we can move the target in straight planes. So it's off to the right, off to the left, or straight up, straight down. Then we can move it off to the side. There's no law that says you can only have one target. So going from one target to a second target, again, starting in straight planes, transverse plane, sagittal plane. So right, left, turning, and then up and down, nodding your head. And then starting to put those targets out of those straight planes. So that now they're moving diagonally. So being able to relocate to different positions, being able to actually move the laser, move your head accurately from one position to another. So tracing with the headlamp laser, tracing starts simple, straight lines, piece of paper on the wall, just straight lines, and then maybe diagonals. Typically, diagonal is harder than a straight plane, straight line. It's still a straight line, but it's a diagonal. So upper left corner, bottom right corner of the paper, as an example. And then curves are much harder. And then as fast as you can go, but as accurately as you can go. So you start adding in speed. So I'm not a big fan of asking someone to move in a certain way or hold their head in a certain way unless I've given them the ability to do that. So oftentimes we talk about posture and maintain that posture. But, if they don't have the endurance in the trunk and they don't have the endurance and strength in the musculature around the neck, then it's not fair for me to ask them to do that. So spending a lot of time on muscle function, which is endurance, strength, and control. And if you think about it, right, so we know physiologically it'll take at least 6 weeks to get hypertrophy in a healthy muscle. So, and when you have a patient who has had, let's say, a traumatic event like a whiplash injury, their muscles are probably not normal. And so it's going to take them longer, right? So that's going to take probably the longest. I can get range of motion and mobility in a joint with manual therapy in one visit. That can happen really fast, but I can't stabilize and improve muscle function until the muscle can actually do that. And that might take 8 weeks, 10 weeks, 12 weeks, right? So for me, the sooner I can get started on the strengthening, the better, because I know that's going to take the longest. So I'll get going on that. And I would even prioritize that over, and I know you've got some mobility issues here, but let's get started on your exercises. Now, last thing I want to say is we haven't talked at all about pain, which encompasses everything, right? So if it's painful to move over there, I have to deal with the pain, because if you have pain, you'll have arthrogenic inhibition of your ability to recruit your muscles. So you just cannot get your muscles to work if you have pain. So my priority, if there is pain, that is going to be always the number one priority. And so whatever I can do to reduce that, I will do. And if in the beginning, if I see someone who has just, been injured, and and everything hurts, guess what? My valve's done. To your question about what do I evaluate? My evaluation, it hurts. It hurts through that. Okay, it hurts. Touch. Oh, I'm done. I've touched it. It hurts. Let me get an ice pack, and let me get you calmed down. Let's find you some positions that are good. Let me get you in a collar so you can rest. Cervical collars have gotten a bad rap, but in the same way, I would put a severe ankle sprain in a boot and let them walk around on it. I would put someone in a collar, let them take it off, move around, put it on. Once an hour, you take it off, move around. You're not going to get stiff. And you know what? Actually, if you get stiff, I don't care because I can get the mobility back. You get a little weak. Yeah, I care about that. All right, take it off or do the isometrics in the collar. Or if you're wearing it at night so that you can sleep, right? Sleep hygiene. Now we know so much more about sleep, the importance of sleep hygiene. And if a collar will let you sleep, it's not like you're missing out on any exercise or movement when you're asleep anyway. So judicious use of a collar, in my view, is important because I need to deal with that pain. So we get rid of that. That allows us to do all the other things.
And also what you're talking about is something we talk a lot about with our patients, where if we're asking them to do things that really provoke their symptoms and kind of send them more into that wiring of their brain, like, hey, every time I do this, I'm going to feel terrible. That's not going to get us anywhere where we want to go in terms of progress. So that's what it sounds like you're also doing when it comes to pain. If this is painful, you're not telling them push through it. You're not saying no pain, no gain. You're taking baby steps and really stacking the more positive experiences with movement in order to, again, get them back to where they want to be. You and I had prior conversations prior to this podcast about how in some centers it will be like a vestibular therapist treats this, and then a musculoskeletal therapist treats the neck. What are some challenges that we face as a physical therapy discipline in terms of communicating between therapists or having one therapist that treats both aspects of care really well?
I'm a little biased here, but I think if you're going to be in this space and treating patients with dizziness, particularly if you're seeing a fair number that are traumatic onset, you need to be able to manage both the vestibular issues and the MSK or the orthopedic issues. I think it's better that one person manages all that. The patient will have a better experience. They'll have and I have no data on this, okay? I'm just putting this out there, that the outcomes will be better and they will be achieved more quickly. Now, clearly that is not many people have that skill, but that's what I run around the country trying to do, is train people to, because it's not really that hard. I just say, I mean, if I can do it, anybody can do it. But the next best thing would be to exactly what you're talking about, Abby, which is to have a team, right? But you have to work closely with each other. So the vestibular therapist can talk to the musculoskeletal therapist, the one who's treating the neck, and say, look, when they do this, this is what happens, and they're complaining of this pain, whatever. And then the musculoskeletal therapist, the one treating the neck, says, well, every time I touch the neck or I do this or I have them do this exercise, they get dizzy, right? And so you have to problem solve your way through that together. And it's not something in my experience that you can do electronically. Like, you can't text your way through that. You can't email. You can't. You have to face talk to one another and say, this is what happened. And I know that that's an extra burden on. We are already burdened with so many things already, and that's an extra burden. But in my view, patient comes first before us. They are the priority, and you have to do what you have to do to get them better. If you are seeing a fair number of these folks, then if you are a MSK therapist good with the neck, you need to learn the vestibular side. At least familiarize yourself with that. And then if you are in the vestibular world, you should gain some skills in at least examining the neck so that oh yeah, the neck's definitely involved here. but it's really not a huge leap from that to being able to treat the neck. And there are very, very simple techniques that you can do, that you can learn. And I know you can learn them because I've 25 years of teaching people in a 3-day course. And I'm not teaching like wildly crazy stuff, right? It's kind of basic things. Just be familiar with it, be confident, and you can make some nice changes in their neck that will go a long way to improving their overall symptoms.
I have to say, I'm definitely in that vestibular realm where I have recognized actually for years now that the neck is very important in this aspect of it. But I have to say, I do really want to brush up on my skills. I do want to take everything that we're actually talking today and start beefing up my evaluations and doing more with my patients in regard to their cervical spine, just because you're right, there's so much more that we could be doing for them and should be objectively measuring, and also just working with them in terms of treatment. I love that this type of treatment is very much the same as vestibular therapy in the way that it's very individualized to each person. And there's really no set pattern or protocol to follow. It's really going to, treat what you see, treat how that patient's feeling. If they're giving you feedback on something, you have to listen to that and go with it. So I think that where I might have been a little bit more intimidated initially, that having that comfort of knowing that this is the exact treatment approach I take already with patients is comforting. It's just brushing up on those skills.
If I could say one other thing, in terms of simplicity, you'd asked about examination techniques, and you won't find this in a book or study yet. But if you have somebody who's sitting in front of you, let's say sitting, but they're static in front of you, and they're saying they're dizzy, right? They have some low level dizzy, and it's not spinning, it's not vertigo, right? They feel off, they feel woozy is a word I hear oftentimes. Their head feels light, but not lightheaded, like they're going to pass out from standing up too fast, orthostatic hypotension, but actually their head feels light, like a helium balloon, and it's sort of floating there. Those kinds of things. Those are those hallmark, and they're saying they have neck pain. Those are those hallmark presentation symptoms that I'm looking at. You're not going to find this in a book, but if you do just static cervical manual traction, so let's say you're sitting there, just come behind them and just lift the head, right? And just unweight it. You don't even, I'm not saying pull the head off the neck. Just unweight it a little bit. And there's some techniques to do it to make it comfortable for the patient and so on. But if you do that and they say, ooh, my dizziness is better, that to me is, I can't see where else that would be coming from. As long as I haven't, moved the head around and jostled the head and accidentally stimulated the vestibular system in the ears. If I'm pretty careful about that and I just get them to unweight the neck, and they go, that's different. That's really hard for me to say it's coming from anywhere other than the neck. Or let's say you have the patient and they're lying on the table, right? And you haven't done anything to them. So you haven't put them in a Hall pike, but they're just lying there, and you just leave them there for a minute, and things settle, and it just stays at, let's see, what number? 3 out of 10, whatever. You just do a little bit of traction. And if their symptoms change, to me, it's got to be coming from the neck. Well, so let me qualify that. Sometimes you put your hands on somebody and just that stability and the extra somatosense. Oh, there's my head. Okay. Sometimes that'll drop it. So just if it drops a little bit when you put your hands on them, then you just wait, right? And then when it steadies out, then add the traction. And my experience has been not immediately, but very quickly. Like you just put traction and they'll go, huh, it's getting better. I mean, you don't really have to wait that long. So that to me would be another thing that I would test when I'm thinking it's the cervical spine. There are 3 papers now looking at a traction manipulation technique for cervicogenic dizziness that have shown both short and long-term improvements immediately after, and then maintaining that for some time. So it's interesting that we have the treatment that works without necessarily the evaluation, but can you see what I'm saying? So this is an example where, well, if traction works, it helps you. Guess what's in your future? traction, as a treatment. And it's not that complicated to do, right? And I don't use machine traction. I do all manual or towels, things like that.
I've noticed a lot of great success with light manual traction. And I'll do that a lot with patients, especially after like a long session. If we're getting to the point where we're doing a lot more, they're moving a lot more, I like to end with some manual therapy techniques, not only to ground them and help diminish symptoms, kind of bring down that fight or flight response that we just stirred up by doing exercises, but I find that I get a better response with that light manual traction, laying down, letting things calm down. They leave feeling 1,000 times better, which is nice, rather than sending them out the door dizzy and like not wanting to come back. But I think that's a really good point to just add that little bit of traction to that evaluation to see if that changes symptoms. And you had mentioned with the lightheadedness, this feeling with their head. Could you also see complaints of heavy-headedness? I get a lot of complaints of heavy-headedness with patients that we end up doing a lot of work with their cervical spine to some success. But is that cervicogenic, or is that something else that I'm assuming is cervicogenic?
Yeah, the way I would look at it, okay, I'm biased because I would say, yeah, of course it's the neck. But the way I look at it is, what would you do if you had a patient with, you're treating for their knee pain or something, and they said, my leg feels heavy? You'd probably go, that's probably a muscle thing, right? Could be neuromuscular. So you check, no, there's no sign of any neurologic compromise. So maybe at that point they're weak, or you've exercised them, and so now you've just overcome their muscular system. So that would be my first thought, would be to look at muscle. It's a nice paper in 2009 in JOSPT by Christensen and Julia Chalavin that looks at cervical sensory motor issues in neck pain, and that's one of the complaints they talk about. And if they have a complaint of heaviness, go look at muscle function. And you can do your classic manual muscle tests, right? We also have in the cervical spine, we have some other tests, some midline tests. So test for endurance, lift your head up, supine, lying on your back, lift your head 1 inch off the table and hold it there for 30 seconds without any other movements. That would be the standard. You can't do that. Oh, you need some endurance. We have, it's interesting that the neck flexors have gotten a lot of press. They have a better marketing firm, I guess, but the neck extensors are important as well. And particularly the neck extensors can also get into trouble. And we've got really nice data from 20 years ago, MRI data, showing fatty infiltrate and fiber changes within the cervical extensor musculature after a whiplash event. So look up James Elliott, his work from the mid 2000s. And so we know, and again, we're looking at traumatic here, but that we need to go after those muscles and train them. So if I hear heaviness, I think, well, first thing would be muscle. Do a manual muscle test, do some endurance tests, and if there are any issues with that, treat it. There's also a small study from the mid 2000s where they actually fatigued patients, fatigued their neck extensors. It was a very small number of subjects, so only 13. Either 7 or 6 or 7 didn't get fatigued, measured by EMG, and the 6 or 7 others did. And they did, the interesting thing is they did posturography immediately before, immediately after, and 5 minutes after fatiguing them. Every single one of the ones who fatigued had increased sway, right? So, and then the interesting thing was they treated them, only their muscles, did no balanced retraining at all, improved their muscle function, redid the test 6 weeks later, 8 weeks later, and guess what? No sway. No, number one, no fatigue anymore because they managed that appropriately, and now no sway. So the muscles are really, really important in the cervical spine. Super important.
I think you just convinced us with that little bit that you added there. Some of my favorite podcast episodes are the ones where it immediately changes my practice in some way. Maybe I'm asking a different question or I'm doing a different test, and you really accomplished that for me today. So thank you so much for coming on our show today. I have to say, too, that I have a lot more questions. So I definitely think we need to have you back on the show. And I think our audience appreciates all the education that you just provided. Where can they find you in the meantime?
First of all, thank you again for the invite. I had a blast. I'd be happy to come back and spend more time with you. My website is www.skillworks.biz, B-I-Z. And my email is rlandell@me.com. So you can find me there. I'm not a big social media guy. Probably should be. If I really wanted this stuff to get out there, I would do that more. Maybe at some point I will do that more. I'm on LinkedIn as well. You can find me there. But my courses are on SkillWorks. But the other thing is, if you can get the target that we use to assess joint position error. It's free. It's right on the website. Just copy it. All I ask is that you leave it alone. Don't alter it in any way, because I have attributions for where I got the idea from on there, and I'd like to keep that there. So Julia Chilavin gave me the idea. That's where you can reach me, and I look forward to just coming back and spreading the word.
Abby, I see that he's teaching one of his courses in White Plains in October. I might see a bar trip for us in the future. We might need to get together and check this out. What do you think?
I think we might have to make it happen. Dr. Lindell, thank you so much again for coming on the show. To our audience, thank you as always for listening. Don't forget to review us. Give us a little rating there. Hopefully it's 5 stars. And also reach out to us. Let us know who you want to hear from and what you want to hear about. Thank you all.
Thank you again.
This podcast is provided for informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition.
The content of this podcast is based on general knowledge and information available up until the recording of this specific episode. Medical knowledge and practices may evolve over time, and new information may emerge that could change the understanding or treatment of vestibular dysfunction. It is important to consult a qualified healthcare professional for the most up-to-date and personalized advice.
The information provided in this podcast is meant to complement, not replace, the relationship that exists between a patient and their healthcare provider. It is intended to empower patients with knowledge about vestibular dysfunction and its management, but individual cases may vary, and treatment approaches should be tailored to each patient's unique circumstances.
By listening to this podcast, you acknowledge and agree to the terms of this medical disclaimer. The organizers, presenters, and creators of this podcast are not liable for any actions or decisions taken by individuals based on the information presented herein. Always consult with a qualified healthcare provider for medical advice and treatment.